In the next 5 lectures, we will be going over the neurologic examination. And the emphasis here is not really on the how to perform the examination, although we'll say a little bit about that. Technique, though, will really be emphasized during the 3rd year neurology psychiatry clerkship. In this lecture, next 5 lectures, what I want to accomplish here is that you understand how the neurologic examination is used to assess both the central and the peripheral nervous system. For example, you take a little pin and you tap the patient's big toe, and the patient says, yes, that feels sharp, like a pin. Well, that very simple little test allows you to assess nerves that go from the big toe up the leg, through the spinal cord, brainstem, and all the way up to the cerebral cortex, and through white matter pathways along the way. So you actually get a lot of information from these quick tests that we can do on the neurologic examination. And we want to be able to use the neurologic examination to localize lesions. So these next 5 lectures are really foundational because a lot of the questions that I will be asking you throughout the course are, can you localize lesions? Can you figure out, is the lesion in the brain or the brainstem, and so on? And it's the neurologic examination, along with the history, that allows us to do that. So we think of the neurologic examination as consisting of 8 parts. We'll say the least about the mental status exam, because psychiatry will be going over that in a little more detail. Then in this lecture, we'll spend some time on speech and language, and we'll just get into probably through the 2nd cranial nerve. Okay, and then we'll talk about the motor exam, reflex exam, sensory exam, cerebellar testing, and gait. And actually, of all parts of the neurologic examination here, just having the patient walk tells you so much because you need to have basically everything else working to have a normal walking. So gait is something that is really important. So just to illustrate this, when I was a neurology resident many years ago, a patient came into the emergency room with sudden onset left-sided weakness, and a CT was performed that showed something like this. And so, this is very impressive, and the patient was rushed off, was seen by neurosurgery, and actually had surgery to remove this. And some of you may be thinking, okay, there's something a little fishy about that, because remember, when you look at a CT or an MRI scan, you want to imagine that the patient is lying flat on their back with their feet coming out toward you. That means this lesion is on the left side. The patient came in with left-sided weakness. And so this lesion, impressive as it is, actually does not correlate at all with the patient's clinical presentation. And so what you're looking at here is something called meningioma, which is a benign brain tumor. This patient has had this for decades, and it was causing no symptoms. Okay, so the patient had an acute stroke in the right hemisphere, and as we'll learn later, head CT is relatively insensitive for picking up an acute stroke. And so the patient really had surgery for this done unnecessarily. Okay, so this also illustrates that as we're prioritizing things here, typically the history is the most important thing for me. Usually if I don't know what's going on after taking a history from the patient, that's bad news. It frequently means, I may not determine what's going on if the history is very confusing. The exam, sometimes in a case like that, the exam will open my eyes to what is actually going on. But the exam works together with the history. Typically, I would prioritize the history, and then you're going to use the exam to often confirm what you think is going on based on the history. And then finally, we have neuroimaging. And the reason I put neuroimaging last here is that especially MRI scans are so sensitive that frequently you're going to find something. Okay, and so what I don't want you to do, when you're out practicing physicians is you just have a complex patient and say, well, let's just get a brain scan and we'll get the answer. All right, so that's not how it works, because you get a brain scan, you're going to find something, but does it correlate with what you think clinically is going on with the patient? And as this CT illustrates, a very impressive brain scan, but it did not fit at all with both the history and the exam, which showed left-sided weakness. So the neuroimaging, as impressive as this is, had absolutely nothing to do with the patient's clinical presentation. So this is the neuroaxis, going from the cortex all the way out to muscle. And so as we're thinking about patients that come in with something common like weakness, your approach to that should be, okay, let's start with the cortex of the brain and work our way down. So we have motor pathways that start in the cortex, that travel through subcortical areas, that travel through the brainstem and spinal cord. And then we have anterior horn cells, which we'll talk about next week, which are lower motor neurons in the spinal cord. And from there we have nerve fibers that go all the way out to the muscle. So those are roots, plexus, peripheral nerves. Then we have a neuromuscular junction, and finally muscle. And so when someone comes in with weakness, really the problem could be anywhere from the cortex all the way down to muscle. And the only way you're going to figure that out is by taking a careful history, and then your examination. We're usually very good with something like weakness in figuring out where the problem is. And again, so super practical, because a weak patient in the emergency room, you need to know, should we image the brain? Should we image the spinal cord? So this is why it's such an emphasis on this course, because it's just foundational to anyone that will be seeing neurologic patients. So we localize first, and then we think about the etiology. Always start with the localization. All right, so let's say we figured out, okay, this is something subcortical, okay, and then that narrows down our list of what the causes are, and then we can begin to think about etiology. So there are a few general rules when we think about etiology. Things that come on suddenly are usually of a vascular nature, like a stroke or a hemorrhage. Okay, something that comes on slowly can be like an expanding mass lesion, like a tumor, where maybe someone comes in. If it's a stroke, like in cerebrovascular disease, they're going to suddenly have weakness on one side of the body. But if you have a slow-growing tumor, they're going to have slowly progressive weakness on one side of the body. Okay, there are a lot of things in neurology that come and go. Multiple sclerosis would be a classic example of that. Okay, we have a whole lecture on multiple sclerosis, but in this condition it's a demyelinating disease of the central nervous system, and these episodes of demyelination come and go. So patients have symptoms that come and go. Migraine headaches would be another example of something that comes and goes. And then we have neurodegenerative conditions where we have relentlessly progressive degeneration. So Alzheimer's would be an example of that. Parkinson's disease, we could list a lot of other conditions here. Now, I'm not going to say much about the history, but I want you to remember that it is frequently, most often, where we make the diagnosis. And so in neurology, we spent a long time, of all specialties, I would say we're right at the top in terms of spending the most time with patients. It's really detective work. You need to get a lot of details. You frequently need to get collateral history from family members to try to put things together. So we want an accurate, chronological, detailed description. If someone comes in with memory loss, you want to know, when did it start? What was the first time anyone noticed something? And then you want to get a lot of, details. Give me some specific examples. Are you having difficulty paying bills? Do you get lost driving? Things like that. And so this was a patient that I interacted with not too long ago, and I thought it was a good illustration of the importance of taking a good history. So the patient said, I've been feeling dizzy recently. So my response was, well, tell me what happens. The patient, well, I get dizzy once in a while, that's all. It's hard to explain. One doctor told me that it was probably a virus. I saw Dr. X who ordered a brain scan, and then he sent me to an ear, nose, and throat doctor who did some other studies and thought that. And this went on for a while. And, when you're initially seeing a patient, you don't want to cut them off. So you let them, share what they want to share. But, I really want to know exactly what the patient is experiencing. And so as the patient then is now emphasizing that, they went to see this doctor and that doctor. What you want in the history is just, I want to hear what the patient is going through. I want a description of what dizziness is. And so really we're not getting anywhere. And so at some point I was able to interject, well, tell me about the first time you noticed the dizziness, which is often a good question. Tell me how it started. What was it like the first time? And the patient said, oh, it's been going on for quite a while. I figured it was probably the flu at first. I'm still not getting the information that I need. So I'm going to repeat the question. Well, tell me about the first time. And the patient said, well, I was at home and I just felt dizzy. I wish I could describe it better. And dizziness is one of those complaints. There are only about 500 things that can make someone feel dizzy. So you can just feel like throwing your hands up. Well, I have no idea. But don't give up. And so I said, well, what were you doing at the time? And the patient said, well, I was just rolling over in bed. Now, you don't know this yet, probably, but for me, that's actually significant. Dizziness triggered by rolling over in bed. So I asked, well, use another word besides dizzy to describe what you felt at that moment. Because dizziness to individuals can mean many different things. Is it lightheaded? Is it room spinning? What do you mean by dizzy? And the patient said, well, I felt like I was on a boat and the whole room seemed to be moving around. I also felt nauseated and I threw up. It was awful. That's about it. Then I went to see my doctor and now we're back into this again. But now we're getting somewhere. Okay, a sense of movement is called vertigo. Okay, so the fact that I just kept persisting, and trying to figure out what the patient was experiencing, now I know we're in a vertigo category. So eventually I was able to ask the patient, well, tell me what happened next at home that day. Patient, that seasick feeling lasted about 10 seconds and I thought I was going to die. Then it was over and I felt okay until it happened later that afternoon. Okay, now we're getting some specifics. It was vertigo that lasted for about 10 seconds. So I said, well, have you noticed that rolling over in bed often brings on these spells? Patient, yeah, and it's funny that you ask, but it seems to often happen when I roll over or turn my head to the right. That will bring it on almost every time. Not that that means anything. And of course, that means everything. We finally got the information we need, and now I can be very confident exactly what this patient has. This is a condition called, we'll learn about later, called benign paroxysmal positional vertigo. It's a common cause of vertigo brought on by head movement. Sorry, my cat is going crazy here. Brought on by head movement, where patients have room spinning and nausea. It's very intense. And the important thing here is you could do every sophisticated test in the world. An MRI scan of the brain, not helpful. Blood tests, not helpful. The history is how you make this diagnosis. All right, so that's all I'll say about the history. Let's move on now to the mental status examination. Okay, and there are, sometimes we'll get into this more detailed. We don't perform this on every patient. So if I'm seeing a 25-year-old man for migraine headaches and, he's very fluent and articulate, he just came from his job as an engineer, and so on, there's no need for me to, ask him, do you know where you are? And those kinds of questions. But certainly if there's any hint of cognitive impairment, then we need to go through and perform this testing. So we'll ask patients orientation questions. What's your name? Do you know where you are? Do you know what time it is? Why are you here? Then we'll ask them memory questions, and we want to know immediate recall and then recent and remote. So I like to ask patients to remember 4 objects, and would suggest you use the same 4 objects or you will get confused yourself as a physician. So I'll ask patients to remember Boston, Mr. Johnson, red car, and tunnel, and then say, can you repeat those back to me? Okay, if they can do it, then you tell them, okay, I'm going to ask you in a few minutes to see if you can remember those for a few minutes. If they only get 3 out of 4 or 2 out of 4, then repeat them again and keep rehearsing it until the patient gets them. Okay, and then you'll check them again later. And one thing that is quite characteristic of patients who have neurodegenerative disease like Alzheimer's is that superficially they can appear quite good. They're often jocular, they're telling stories, But then when you really pin them down and ask some detailed, specific questions like this, you're amazed at how poorly they actually perform. So patients often get a little uncomfortable as we're asking these questions because they feel put on the spot. So I just try to tell them, just relax. I ask all patients this, just do the best you can, no pressure. Okay, and in something like Alzheimer's dementia, a hallmark of Alzheimer's is that patients do very poor laying down new memories. And so typically, they may get those 4 objects when you immediately have them repeat it, but then they can't remember them just a few minutes later. Okay, then we'll test attention, where we give the patient, you can do this several ways. One is to give them numbers, like 7 numbers, and ask them to repeat as many as possible. Then we'll do some math testing. Okay, and later on we'll talk about the areas of the brain that are involved in that. Then we'll do some construction. I like to have the patients draw a clock and put the hands, big hand, little hand pointing at 11:20, or we can ask them to draw or copy a cube. And then we'll do some abstraction questions, like how are an apple and a banana alike? And you will see neurologists ask some weird questions, like do helicopters eat their young? And, most people are going to laugh when you're asked a question like that. Someone with Alzheimer's dementia will seriously ponder that, and they may say, well, I suppose they might under certain circumstances. Then we'll ask for general information, like current events. Keep using Alzheimer's as an example here, but what we often see in Alzheimer's is they watch TV all day long. They watch the news constantly, or they're watching sports. And despite that, they do very poor when you're asking them some basic questions. I like to ask patients if they watch sports, and it happens to be something that I know a little bit about. Well, tell me, who are the players on that team? And so if you kind of engage informally, then the patient maybe feels less put on the spot. There are standardized exams. One that's commonly used is a MOCA exam. We have sheets of these in our office where you can just fill this out. It's a 30-point test. And, so this is helpful when someone has cognitive decline. You want to get a baseline, and then you can follow them over time. So please don't work to memorize this or the previous 2 slides. I'm not going to really ask specific questions there. I kind of want to give you a general sense of how we do cognitive testing. Now, a very helpful thing that can be done quickly, like in the emergency room setting, is to ask a patient to follow commands. Because, again, in an emergency room setting, this takes a little while to do formal cognitive testing. So we can do very quick things like a 3-step command, which would be touch both shoulders 2 times with 2 fingers. Okay, and when you are a 3rd-year medical student, and maybe you're asked during your first week in neurology to go see a patient, and if you come back to the neurology resident and say, well, they're able to follow 3-step commands, the neurology resident will be impressed, right? Because to follow a 3-step command, that says good things about the patient's cognitive function. Okay, the simplest command are midline 1-step commands like close your eyes or open your mouth. 2-step command would be close your eyes and point to the ceiling. Okay, so if a patient can't follow a 3-step command, we can work back and see how much they're able to do. Now, in order to have consciousness, you need to have 2 neural structures intact. One is in the brainstem, and that's known as the reticular activating system. And you need to have 1 hemisphere intact. Notice not 2. Okay, and that means a patient can have a massive stroke on one side of the brain, but yet if the other half of the brain is intact, and if the brainstem reticular activating system is intact, that patient may be awake and talking. Okay, so that's just an important point. Let's use 2 common conditions that cause cognitive impairment. One is dementia, which has been renamed recently as a major neurocognitive disorder. I think everyone is still using the term dementia. And Alzheimer's is certainly the most common cause. More than 2/3 of dementias Alzheimer's. So this is a progressive intellectual decline, but it's not just cognitive. Okay, the whole brain is affected. One of the earliest symptoms of Alzheimer's, as we've already mentioned, is spatial disorientation, where patients get lost. So there are lots of things that deteriorate in dementia. Encephalopathy or delirium, often those two terms are used interchangeably, is more of an acute or subacute change in the patient's cognitive function, and frequently this is due to a metabolic disturbance, like an infection, and the patient gets confused. Or the patient is overusing maybe pain medications, and they get confused. And so there are many, many metabolic things that can happen. Maybe the patient's glucose goes too low or too high, or they have an electrolyte disturbance. Really anything of a metabolic nature in the body can cause someone to be encephalopathic, confused. And so you have a patient in the emergency room who's confused, and maybe you don't know the history. Well, they're just here and they're not normal cognitively. How can you tell if you're dealing with a dementia or an encephalopathy? Okay, well, if you do know the time course, that's very helpful, okay, because dementia, as we mentioned, comes on slowly. There are a few exceptions of rapidly progressive dementias, but most of them come on slowly. Encephalopathies come on rapidly. Dementia just tends to be like every month is a little worse than the last, that kind of a thing. Whereas an encephalopathy tends to fluctuate dramatically. You walk into the room at one moment and the patient is barely awake. You come back later and they're awake and they're conversing a little bit. So we get that kind of fluctuation. But I would say the most important thing we'd want to look at here is attention. Okay? This is normal or near normal in dementia like Alzheimer's. So for example, if we're seeing someone with Alzheimer's and we come in and talk with them, their eyes are open, they're wide awake, they're making jokes, they're interactive, okay, they're very attentive. Whereas in encephalopathy, what this means, impaired attention, is they're a sleepy, confused patient. So you need to come in and, Mr. Jones is kind of half awake, maybe slurring his speech, and you need to keep tapping on his shoulder. Mr. Jones, wake up, wake up. And then you ask a few questions, and then Mr. Jones drifts off again. Wake up, Mr. Jones. So that kind of appearance is not how someone with Alzheimer's looks. Encephalopathies tend to be reversible. Maybe the patient is intoxicated. Well, that's going to wear off and the patient will be back to normal. Dementias syndromes are rarely reversible. They progress. Now let's move on to language and speech. Okay, dysarthria is a speech disorder. So slurred speech is the same thing as dysarthria. So speech refers to the articulation of words. And so causes of dysarthria can be neurologic and non-neurologic. So just for example, one is already talked about. If you have a patient who's encephalopathic, maybe from drug overdose, alcohol overdose, or they have a bad infection, they're going to be confused and typically they will be slurring their words as well. Okay? Or we can have some abnormality of the vocal apparatus that can also impair speech and cause dysarthria. Okay, I'm really not going to spend any time now on dysarthria because I want to really emphasize here aphasia. Okay, aphasia is a brain disorder, usually in the dominant hemisphere, in the left hemisphere, which is dominant in 95% of right-handed people, 70% of left-handed people. So when someone comes in with an aphasia, we do want to know if that individual is right or left-handed. If they're left-handed, we would consider a bit more, well, that this possibly could be a right hemisphere lesion, although even in those patients, it's most often going to be left hemisphere. So some ways to test for aphasia are repetition, naming, having them read and write. So I give patients something simple to repeat, like, can you say today is a sunny day? And then I'll move on to more difficult sentences to repeat. Like, can you say, now that he has come, we must go away. Okay, and in some patients, I'll move on to very complex sentences to repeat. Naming is great, so we'll have them maybe point to your knuckles or eyebrow or glasses if you wear them. Or you can point to more difficult things like a door hinge, or point, if it's a fluorescent light, you can ask them what type of light is that, to check for naming. And then we'll have a patient read some simple sentences, and then we'll ask them to write. So these are all 4 great ways to attest for language function in any patient suspected of having an aphasia. So let's start with the expressive or Broca's aphasia. And Broca's area, as we talked about, is on the posterior inferior frontal lobe. And so the importance here is when you have a patient that sounds like they have an aphasia, the question you want to ask right away, is it fluent or non-fluent? Okay, if it's non-fluent, meaning patients are getting very few words out, they're just struggling to even say anything, okay, that's a non-fluent aphasia. In other words, it's an expressive or a Broca's aphasia. So if it's isolated in Broca's area, then they understand just fine, because Wernicke's area is where you understand language. They can't speak very well, but they can understand what's going on. So this would be a patient, that would be great to ask them to follow 3-step commands. Okay, and they may not be able to speak, but they can follow 3-step commands just fine. Now, Broca's area, remember, is right next to the motor strip, and this is all supplied by the middle cerebral artery. And so a common cause of an expressive aphasia is a branch occlusion of the middle cerebral artery that supplies Broca's area and the motor sensory strip. And so these patients will not only have an expressive aphasia, but it will also have right-sided weakness or hemiparesis. So those 2 frequently go together. Okay, so remember we have Broca's area here. And sometimes if the lesion is small, this can be subtle, and the patient just kind of stumbles over their words. They have effortful speech. Some patients are almost completely mute. I used to have a patient I haven't seen in quite a while, and all he could say was pee-pee. And you ask him any question, and that was all he could get out. And so patients with an expressive aphasia frequently are very frustrated. Depression often goes along with that because it's just so frustrating to understand and not be able to communicate. All right, now let's move back to Wernicke's area. So remember, the most important part of Wernicke's area is here on the posterior part of the superior temporal gyrus. A little bit of Wernicke's extends out here into the parietal lobe. Okay, and so this is if we have an isolated lesion in Wernicke's area, this causes patients to be fluent, because Broca's area is where you get the words out, right? So they're talking a lot, but they don't understand very well what's going on. Okay, a hallmark of a Wernicke's aphasia, and on Friday I'm going to show you a video of a patient with this in class, is that they make lots of paraphasic errors. And so these can be words that don't exist, or it can be a word that exists but it's used in the wrong location. So the grass is greel, or the grass is blue. Both of those would be a type of paraphasic error. So when someone has a Wernicke's aphasia, we want to listen to them very carefully as they speak, and we'll look for those paraphasic errors, which are really characteristic. Okay? So a patient with a Wernicke's aphasia here can be rather frustrating. You want to take a history, you want to get some information, and what you will notice is what the patient says back to you has very little to do with what you ask them. Okay, and so these can be challenging patients. Now, if we have a very large stroke here, okay, then now the patient is going to have a global aphasia. They're going to have an expressive aphasia and a receptive aphasia. And so they can't speak and they also can't understand. So these patients are really devastated. A conduction aphasia refers to a lesion of the pathway that connects Wernicke's and Broca's area. Remember, this is called the arcuate fasciculus. And so if you have an isolated lesion of the arcuate fasciculus, these patients often just come in with kind of a vague language problem. They're just not getting words out very well. It's often really subtle. But the main thing that they can't do is repeat sentences. So this is really an exam finding. Okay? So repetition then is really important. And so when you ask a patient to repeat, can you say, today is a sunny day? Well, they understand, right? They know, okay, the doctor wants me to say today is a sunny day. But to be able to say that, you need to move the pathway forward to Broca's area and then repeat what the doctor just asked you to do. And if you've got a lesion in the arcuate fasciculus, then these patients are very poor at repeating sentences. Repetition is going to be very difficult for any patient with a lesion of Wernicke's, arcuate fasciculus, or Broca's. So repetition is impaired with any lesion along here. What's different about a conduction aphasia is that that is the primary problem that they have. Okay, it's not like an expressive aphasia where they get very few words out, and they understand, so it's not like a Wernicke's aphasia, it's mainly just with repetition. Now, some patients have lesions, usually strokes, that are around Broca's area or around Wernicke's area. Okay, and so these are called transcortical motor and sensory aphasias. And so usually these are called watershed infarcts, which means an area of the brain that doesn't have quite enough blood flow. Okay, so the stroke occurs around Broca's in this case. We'll talk more about this later, and around Wernicke's area here. And so a transcortical motor aphasia looks a lot like a Broca's aphasia. It's a non-fluent aphasia. Okay, but because Wernicke's, arcuate fasciculus, and Broca's area is all intact, they can actually repeat sentences well. Okay, a transcortical sensory aphasia, and just last week I had the best example of this I've ever seen in a patient. Okay, and he looked like he had a Wernicke's aphasia. He just was sort of saying things that didn't make sense. He didn't respond to questions very well that I asked him. Okay, but surprisingly, he did quite well repeating sentences. Okay, so preserved repetition is something that is kind of a hallmark feature of the transcortical motor and sensory aphasias. All right, and here is a table sort of summarizing everything that we just talked about.